This meeting is being recorded.
It's not, are you still putting it in presentation mode? You're on mute, Jenny.
I either have to go full presentation or I can't, like I won't be able to do anything else, so I guess.
I think that's fine.
Yeah.
I'm okay with that. I'm going to admit everybody now.
Okay.
Do you want, your slides are still showing. Do you want to unshare or?
What?
Obviously, do you have the slides showing as people arrive? Is that what you mean? Is that?
Oh, do we not want to do that?
No. I just realised what you're doing.
Yeah.
Is that what you're doing? I don't know.
Yeah.
Hi, everybody.
Good afternoon, everyone. Afternoon.
Very popular session. We had 130 people sign up for today. Really nice mix of people. Jenny, the presentation is not showing in full screen yet.
Let me just try again.
Would you mind letting?
Is it doing it now?
No, it's not.
Okay, I'm just gonna. I'll just have to do this.
That's it. Great. Thank you. Welcome, everybody. Slight technical issues to kick us off today. Where would we be without them? We won't have any excuses when we're all meeting up in person, hopefully. So yeah, I was just saying we've got quite a few people that have signed up today. We had 130 people, which I think really speaks to how this is on everybody's minds at the moment in post-COVID, post-vaccination world. Do you want to go on to the next slide? So today's session is about, we're doing a bit of a spotlight on care coordinators and how they can be used in the PCN. Could you go to the slide with yeah, that's great. So yeah, I work as a PCN advisor. Many of you may know me for my role as the Regional Learning Coordinator for London, supporting the network of social prescribing link workers. And we realised that actually there was a real pressure on link workers to work with PCNs to understand what the role was. And as the personalised care roles expanded in primary care, we went back to National and said, we really think that there's a need for PCNs to receive some support in embedding these three roles. So they gave us some money to have a couple of PCN advisors across London. So that's myself and Hina. Actually, could you go back to the last slide? So the focus of the role is really to being a bit of a network across London. There's many of you trying to think about how to use these roles and how to best embed them within your primary care network so that they are effectively tackling health inequalities in the way that they were intended when the DES contract came out. So these events, many of you may have been to some of the previous events, are designed to convene those of you across London who are charged with employing, managing and embedding these roles, and to really create a bit of a platform to discuss some of the things that are to platform some of the examples of best practice hear a bit more from some of the people that are supporting the embedding of these roles, and have a chance to meet each other and share some examples of what you're doing, and possibly even your challenges, and talk through what, hear if other people have got some solutions to the challenges that you've been facing. I work at Healthy London Partnership as part of the social prescribing and personalised care team, and have got a long history in working with the voluntary sector and taking asset-based approaches to supporting our communities. I want to also introduce Hina, who I share the role with. Wonderful Dr. Hina, you around?
Yes, thank you. That's really kind. Hi, I'm Hina. I'm a GP in North West London, and I share the role of PCN advisor with Liana. Thank you so much for joining the session today. It's, as Liana said, it's really generated a huge amount of interest, and so we recognise this is something that a lot of PCNs are thinking about, embedding into their work. Our specific focus, in particular, my area of interest is on health inequalities and how the R's roles can be used in addressing health inequalities in London, and I'll be speaking shortly about that.
We've also got a very important member of the team, Jenny, who has joined the team at HLP last year, and has got a really fantastic background in data and population health. Jenny, do you want to introduce yourself? You're on mute.
Sorry, I tried to use a keyboard shortcut for unmuting myself, which apparently doesn't work. Hi everyone, I'm Jenny. I work with Liana and Hina at the team at Healthy London Partnership. As was mentioned, I've got a background in data, so I'm interested in how this can help personalised care, social prescribing and care coordinators to reduce health inequalities. I'm also supporting Ali Hassas, who's the regional mentor for care coordinators. So Ali, if you want to introduce yourself too, that would be fab.
Sure. Thanks, Jenny. Hi, everyone. As Jenny said, I'm Ali Hassas. I am a GP in London, and I am in an interim role as the London Care Coordinator Mentor, kind of connecting care coordinators and getting a sense of how things are. And I'll be speaking a little bit about what care coordination could be about, some of the challenges with Jenny. I'm also have other roles, but I'm involved in supervision, mentoring, coaching at Health Education England for many years. Really lovely to be here.
And many of you, know the drill, the Zoom drill, introducing yourself on chat. If you would like to, there's quite a few of us today, so if you want to change your name on Zoom, if you hover on the 3 dots in the corner of the picture of your screen, you can change your name if you want to include your role. It might be interesting for each other to see who else is in the room. It's an informal session, and we are hoping to cover some of the things. Many of you in your sign up were telling us some of the things that you wanted to hear about in today's session. You want to hear about the role. You want to hear more about what the role of the care coordinator is, what its purpose is, and how it can be used to support the work of primary care, particularly in tackling health inequalities. There's a lot of challenges around recruitment and how to support those that are in the roles, and many of you here are wanting to find out more about how you can better support, manage and make sure that your care coordinators are well trained so that they are really flying in their jobs and supporting your populations. There was some interest in how they work alongside some of the other R's roles, particularly the personalised care roles and social prescribing. Hopefully all PCNs now will have a social prescribing link worker, many will have more. And so there's, in the absence of care coordinators being in the system, we know that some of the social prescribing link workers were perhaps occupying some of the aspects of a care coordination role, and many places it will be more of a blended role. So it's really important to think about when they're wearing their social prescribing hat and when they're wearing their care coordination hat, and where there are more, where the team is a bit bigger, how those roles can work together. So hopefully we'll cover some of that. And there was some interest in what support is out there within your local systems. So we'll do our best to cover all of these things. We've got a really great lineup of people speaking. But as I said, it's an informal session. Please feel free to chat to it, put comments in the chat, connect with each other. I'll be holding today's session, but we really want to hear from you guys. If you've got some interesting examples or things that you want to share, then please feel free to put your hands up and we can bring you in. We've also got a means, because we looked this morning and saw 130 people had signed up when we were expecting more like 50, that we want to be able to cover all the questions that you guys would like answered. So if you hover your phones, the photograph function of your phones over the QR code on the screen, or join us on slido.com #PCN, you can post questions in there and see questions that other people are asking, and you can vote up your favourite questions. I know we've got an hour and a half today, and that seems like quite a long time, but I'm sure it will go very quickly. And anything we don't get to cover in today's session, we can certainly pick up outside of the session. So it's really good to hear any question you have, pop it in that, pop it in there if you can. And vote up your favourite questions so that we can make sure we're covering the things that you want to hear. So we're going to hear, as Ali mentioned, he's going to tell us about the role and what his work as a mentor supporting care coordinators across London. There's been a piece of work to look at the challenges that care coordinators are facing, and we'll also hear about some practical solutions maybe to tackle some of those challenges. We're going to hear from a care coordinator who is one of the champions, and a little bit more from Hina around how some of the care coordinators around London are being used in a really interesting way to target health inequalities. We've been going around London meeting people who are wanting to ask us questions about how to better embed these roles, and share some of their good work. And there'll be more at the end of the session on how you can access some of that additional support. We want to hear from you if there's examples that we're not covering, and there will be a chance for Q&A, but I may bring in some of the questions that come up in the Q&A throughout the session if it's specific to a speaker. And then we'll tell you a bit more at the end of the session around what some of the ongoing support looks like, how you can get more involved, additional pieces of work that we're developing, and what that we're going to be doing a spotlight on health and wellbeing coaches next month. So do we want to go to the next slide? Is this on to Ali? So yeah, Ali's been doing a fab job convening the network of care coordinators across London. So yeah, over to you, Ali. Thanks,
Leanna. Jenny, can you unshare your screen if that's okay? Great. So I'm going to say a little bit as an overview about care coordination. I know there's a mix of people in the room. It sounds like we've got care coordinators, managers, it's a great mix, and other personalised care kind of workers. So I'm aware some of this won't be new information for some of you. For some of you, it would be totally new. Please ask questions along the way. Liana will look at the chat, and hopefully I'll cover them. I'm going to give you a sense of where we are in London. We have, Jenny's going to tell you about the survey we've recently had, and then maybe talk about some ways forward, because I guess it's really, it's a shared experience that this is still quite a confusing landscape for us all in general practice. We're all trying to make sense of how care coordination, oh, that's definitely not me. Thanks. We're all trying to make sense of it. And I guess if we were trying to start this again, we probably wouldn't have planned this in this way. The analogy that comes to mind, I was saying earlier, it's like we're all being asked to fly a plane, to build a plane after it has taken flight. And we're all trying to figure it out and add bits to it. And that, in a way, is why it's so difficult, but also it does give us some potential opportunities to shape it for how our practices and our patients want this to work. So I'll say a bit more about that. And I think I want to acknowledge a couple of other things. So care coordination is more confusing in many ways because some of the other R's, as they have come along, have been very clear in terms of what the role's about. You know, you almost, as a paramedic, you have a clear sense of what they do, what the training is, and so they can kind of slot in to a team. Same with some of the other personalised care roles. A coach, most people now have a better idea of how a coach can be useful. Whereas care coordination and the first kind of documentation that came out left it a bit more vague. And I think that's why some people are finding it still quite difficult. And then we've had on top of that, the fact that the link workers have been around now for a couple of years. Most of us are now very used to how that works, how they work, how they can contribute. And many link workers have kind of a broad scope of practice. So in some areas, they are doing the work that some care coordinators are asked to do or expected to do. And I think in some of your patches, there's going to have to be some renegotiation, some rethinking, but also some collaborative working. There may be overlaps around this. So it's not a clear picture, but hopefully you can get a clear idea by the end of it. And then the other context I think that's relevant is that with COVID and the relaxation of the rules, a lot of the care coordinators were diverted to help with the vaccination program, doing admin work, and that was great. We needed it. They stepped up to the role. It's been fantastically helpful, but that is not what their role is about. And I think one of our challenges in London is to really now stop, pause, and think about how we shape this going forward. As an overview, I guess thinking about the three roles, there's some slides which I'll share with you, but I see it very simplistically. I mean, I'm going very simplistically that there's a lot of overlap between many aspects of the roles. But the way I would see it is that you have, if the patient in front of you essentially has needs linked to accessing community organizations, for example, isolation, other kind of third sector organizations, that's what a need that is there. That's where a link worker could be particularly useful. If your patient, one of the challenges is behavior change. If you really want to kind of help your patient change behavior around an outcome they want to focus on, that's where a health and wellbeing coach can be particularly useful. And if you've got patients who have complex needs, long-term conditions, multiple inter kind of mingled conditions, or patients who are really struggling to make sense of how the system works, how to navigate this landscape, and they're at risk of being kind of forgetting things. That's where I think care coordinators can be really valuable, to really work with the patient to develop a personalized care plan alongside the clinician. And I can say more about that, but that's how I see it. So in a sense, if you've got somebody who needs behavior change, think of the coach. If you've got somebody who needs to be connected into the community organizations, think of the link worker. And then if you've got somebody who needs connecting into the various bits of the landscape and needs personalized care planning because of their complex or chronic needs, think of your care coordinators. But there is going to be a lot of overlap and there's a lot of joint working around this. In London, we now have, so part of my role has been to really find out what we've got in London, we hadn't known. And we have, I think, 160 care coordinators at least in London now, which is a fantastic number. And we have also, every ICS now has at least one care coordinator champion. In many of your areas, more than one champion. These are care coordinators who've put themselves forward voluntarily to really connect care coordinators in your local area and be a kind of conduit within your regions, but also to help new care coordinators link in with an existing network. So one of my aims is that we develop lots of local and regional peer support networks, because it is a particularly difficult place to be as a care coordinator at the moment. Some of you will know in your own experiences. It can be isolating. It's people are not sure what's going on, what's expected. So my task is to figure out what the experience is and how we can connect people to then develop support. And one of the things we've done is we've put out an experience survey, which Jenny will talk about. So we have a better idea of some of the themes that care coordinators are experiencing. We'll share with you. We have an incredible group, and we've started meeting once a month. Some of you I know are part of that. We have an incredible group of care coordinators in London, and it's just so lovely to hear. They're an enthusiastic, motivated, often quite high-skilled practitioners who really want to develop. They really want to get to know how this how they can help patients. And some are finding it more frustrating, some are finding it quite scary. But I think there's a real resource, and we have, I think, in the next few months, an opportunity to really help them take ownership of this role with your help. And then I'm going to talk about a couple of things. One is the vagueness of what's expected. So nationally, the NHS England team, we have been feeding back quite a lot of the themes that have emerged from PCNs, managers, practices, and care coordinators. And there's now going to be a care coordinator roadmap coming out. They've been working on it. And that will spell out some of the questions people have been asking. What's expected of supervision, for example? What is supervision about? What do we need to think about? What about time? How much time for training? What does training look like? The idea being that you have a document that you can refer to and you can add to locally, but until now we haven't had anything central, so everyone's done it slightly differently, which has its gains. There are gains and losses. So there's a national working party looking at the roadmap that should be coming out, I think, in March, but it may be a bit after March. Then there is, and in that we'll outline some of the training pathways. And we can talk about training if anyone's got questions about that. So I'm just going to share a couple of the slides. Can you, Liana, can you give me a thumbs up if you can see that? Just so I know. Yeah, okay, great. So this is going to be in the slide pack. It's just the kind of the bullet point headlines of the 3 roles, this personalized care team. And I really, the way I think of this is that it's like having your own MDT within the PCN that can work together. They can have lots of overlapping skills, and but they can have a very individual workload. Care coordinators fundamentally are tasked, they should be tasked with patient-facing work. So care coordination is not purely an administrative role. And I think that if that's one message you can take away, this is not just a rebranding of your practice admin team, another administrator to do quaff admin, to do searches all the time. Admin's part of that role, but fundamentally, it's about having somebody in your team working with a GP or GPs or clinicians, connecting with patients, linking with patients, and coordinating the patient's care around their needs. So that's the first thing, not pure admin, patient-facing, and that requires then certain bits of training, certain bits of support, which is different to your usual admin team. They act as a bridge between primary care, community care, secondary care. There are now care coordinators in secondary care as well, which have a slightly different role. And they act, I guess, longitudinally. So they're offering, what they can offer, which is something that we all increasingly need, is continuity of care alongside the GP. So I want to just kind of highlight some of the emerging contexts post-COVID. This won't be news to you, but I think it's useful just to flag it. We are all in our practices facing increasing patient needs and increasing presentation of multiple complex issues in each appointment. Your GP, the GPs in the room will know that. People coming with things they've been sitting with for a couple of years now. Twinned with patients finding it hard to navigate the system. You know, referrals are different. Is it, you know, online appointments, remote appointments, systems are different. And clinics kind of changing how they do things. So there's increasing barriers to accessing care. And the most vulnerable patients are finding it harder to advocate for their own needs. So self-advocacy is becoming a challenge for the people who are most vulnerable, have got most complex chronic needs. And twinned with that, GP capacity, I don't need to tell you, is, you know, we're struggling with GP capacity, GP time, for all kinds of reasons. Continuity is being affected because of the way things are happening, triage and follow-ups. And what we're seeing, you will know this, is incredible numbers of increased GP anxiety, overwhelm, the sense of moral injury where GPs really want to spend more time with patients, really sorting these things out, but they just cannot do it properly, do it justice. And that's leading to burnout. One of my other roles, I work for an organization called NHS Practitioner Health, which really looks after the mental health of doctors. And our numbers have just exploded over the last couple of years with GP burnout. and people consistently say, I really want to be able to spend more time, do more, but I cannot do it because of the time pressures. And then marry that up. I know this is going to sound a bit depressing. Bear with me. It gets more positive. Marry that with increasing patient annoyance, dissatisfaction because they can't get through, patient anxiety because they are worried about things they haven't accessed a doctor for healthcare advice about, confusion and distress. And I think what we're facing, all of us, is the potential of an increased risk of oversights, errors, and inadequate care, where things will get missed in the coming year. We're already starting to see it because there's just not enough time. And the kind of the inverse care law is likely to get worse. You know, the people who need access to care most are less likely to be able to get it. And I think this is why then now is a perfect time actually for care coordinators to become embedded in primary care and for us to really create this, because I think personally care coordinators can address a lot of these issues. Fundamentally, they are part of the personalised care team, so they can spend time with patients developing the personalised care plan, and I mean a meaningful plan, not sometimes the kind of the reductive thing that we have to do to tick boxes, really sitting with people and figuring out what they want and how they want it, what matters to them, and help patients advocate for their own needs increasingly, especially when they're going through the system, you know, hospitals, secondary care, tertiary care. It's a really difficult place to be as a patient at the moment with the pressures in secondary care. They are an incredible resource for offering you, our patients, continuity where you can't get it with GPs at the moment, and being a point of contact that patients can come back to, ask questions from, and help patients make sense of the complexity that they face. There's something about sense making that I think care coordinators can be really valuable in. They are perfectly positioned to help communication between the patient, the clinical team in your practice, but also between primary care and secondary care, really helping these strands of communication not get lost and helping coordinate, you know, really thinking with the patient about what's coming up, how they may need to link X and Y, how they might need to prepare for a hospital appointment, what they might want to ask their consultant, what's important following their GP appointment, what do they want to have spoken to their family about or their carers about before they go to the GP, what about the blood tests, what about your other needs in the community, how do we link you in? So it's something about having a resource where they can really coordinate and link the different aspects of patient need. And with all of that, I think we will all benefit from a more efficient and appropriate use of appointments, because we all have patients who will access appointments, and actually it's not really relevant. For me as a GP, I'm probably not the best person. There are people equally well trained who can help them, because it's not about clinical care. Of course I could do it, but as a limited resource, I think we need to think of other ways of addressing patient needs, and therefore we can be more efficient, helping improve clinician time, increase clinician time and capacity. And for me, this becomes really important, and I really can't stress this reducing this risk of oversights and errors, because things will fall through the net over the next year because we are so busy. If you have duty doctor surgeries, you'll know how stressful it is. And fundamentally, connecting us with a bigger theme, that the aim of personalised care is to reduce health inequalities in our areas, and that's where care coordinators can really also be a useful support as part of the personalised care team. And you will think of other values that they can bring, hopefully by the end. I'm going to pause for a second because we, as I said earlier, we did a survey, an anonymous survey of all care coordinators in London, and we pulled the results. And Jenny has done a fantastic bit of work and shared that also with each integrated care system area. But I'm going to pause to let Jenny give you some of the headlines about that, and then I'll pick up the next bit. Jenny, are you okay to?
Yeah, thanks, Ali. Yeah, so the top line results from the survey that we ran back in December We asked some questions about kind of the background of care coordinators, their current working arrangements, but also what their upcoming challenges are, needs, and what could be done to support them more in their roles. So we found out that it was a relatively new workforce, although quite a lot of care coordinators have already been working in primary care for several years. They're quite new to the care coordinator role. But there was a proportion of care coordinators that had no health background at all. So this shows that there might be different things needed to support this workforce. It's also a very varied role, as we've heard before, and we'll hear again later with the real life examples of the work care coordinators doing, that it really varies depending on the population need and the PCN's structure and priorities, what care coordinators will be doing. And a major thing that also varies is the fact that some care coordinators work at one GP surgery versus multiple, and even sometimes more than one PCN. So this means that they face different challenges. Only half of care coordinators received induction, and being a new workforce is quite important. Often it didn't cover loads of different elements. It focused on one aspect of the role, or didn't include personalised care. And experience of supervision also varied. Even though there was quite a good coverage of supervision, it wasn't sometimes well received or rounded in clinical and personal aspects. However, we did hear that some things are going well broadly across the cohort. Building relationships across the system, linking best practice to different GP surgeries and sharing, supporting patients and making progress against specific work projects, specifically in things like COVID vaccinations and different cough targets, and learning about areas of patient need. But overall, a comprehensive package of training for care coordinators is needed in the early stages into the role, but also throughout as they develop and work with more specific patient cohorts. And first and foremost, this covers role clarity and boundaries, which we'll continue to highlight throughout today, but also personalised care and how care coordinators can link in with the other roles, specifically looking at clinical conditions and caseloads as well. And also IT and EHR systems, such as System 1, and how to best pull off patient lists and find those specific cohorts to work with. But I'll hand back over to Ali if he's got any more reflections. I know it was mentioned that the roadmap is coming out that highlights this.
Yeah, thanks, Jenny. I guess what I would say is that the picture in London mirrors the national picture. So this has been shared with all the other national teams. And actually, these are the same themes are coming up consistently. And that's why the roadmap is being put together nationally, because there is a very variable experience. There are areas where care coordinators have really taken off, and they've got supervision, support, training. And then there are areas where there is very little induction, roles not clear, and people are not quite connected with the systems and patients. So, and I'm aware there are some questions in the chat, and I'll just do one more slide and hopefully answer some of those along the way. So, and this links to some of the things that what we're finding, what really makes a difference. So in areas where there are care coordinators in place and they really are starting to thrive, these are some of the common things. There's something about having a meaningful induction for care coordinators with training and supervision. And that's in the roadmap. I think the draft proposal is to break it down into different stages. So the stage 1 being the mandatory type of training, you know, all the kind of basics that you would do for anybody starting who's patient facing. Alongside that, there are e-learning modules around personalized care planning, which I think all care coordinators must do early on. And then induction and introduction into how your multidisciplinary team works in your area, your PCN, your practice. And then there is something around planning, because given that there's a mixed picture, there are care coordinators who've been in general practice for 20 years in admin and other roles who are now a care coordinator. There are people who've just joined the NHS 3 months ago. There is not going to be one type of induction and training that suits everybody. But based on the care coordinator you have, identifying training needs becomes very important. Some will need induction to how the NHS works, how primary care works, and some already understand how all of that works, so they don't need induction or training on that. Supervision, I think, is really what seems to shift this role. So a lot of the experiences where supervision is often joined, or shared between a manager and a clinician, leads to a better outcome on the whole. And that's partly because, as I said, this is a patient-facing role. And it's really hard because often managers don't get involved in that element of work. It's really hard to supervise a care coordinator fully. And that's why joint supervision, so a GP alongside a manager, often works well. And where this role has been, the care coordinator has been aligned with GPs, so work alongside GPs, ideally having a named GP from the outset to sit with induction and talk about what this role is about. That really does work. And Aidan, I think, is here, who's going to talk. And he's a great example of, he works very closely with GPs. You know, he does a slightly more extended role, but he may do a home visit and he'll talk about it. A GP might say, oh, you're seeing so-and-so, could you also ask about this and update the notes? That's when you know you're working in partnership as part of a personalised care team, really, with a GP. So aligning with a GP. And I think that comes to the point, the question that was in the chat, how complex is too complex? So this is not a clinical role. You know, the care coordinators are not clinicians. They are essentially a resource alongside a GP, and between the GP and the patient. And I would say, if you have a care coordinator who's developed safe relationships, a useful relationship with a GP who can feel able to ask GPs, the duty doc or a named GP, and you set the boundaries around what you want to make sure they have run through you, then I don't think there's an issue around that. There shouldn't be, if they haven't been trained, working outside of scope like anything else. So for example, an example came up early on. Can care coordinators be having end-of-life care conversations? Now, in one area, that's what they wanted them to do. And I would say, well, there is no black and white. No, they can't. Yes, they can. The question is, what training has your care coordinator done? How are you linking the conversation they have with the conversation the GP will have with the patient? Is it part of a series of conversations? For example, has the GP started the conversation? Then the care coordinator follows up with the patient to see if they've got any questions, anything that's unclear. And the care coordinator can then help the patient go back to the GP and ask further clarification. That feels perfectly reasonable. Very different from leaving a care coordinator to do a full end-of-life care conversation on their own. So it's about clinical risk, who's accountable ultimately if something is missed. And I would say they shouldn't be taking any clinical decisions, but they can be taking queries and issues to the clinician to decide, well, what can I do? Who can I access here? Who's the best person to answer this question? I don't know if that answers it, but we can talk in the questions if it doesn't. But my sense, it depends on the person you've employed, the support you have in place, and how safe the relationship is with the GP so they can ask any questions. And where you create a bit more upfront time to allow them to keep asking, you'll find that you can assess their level of competency and you can assess how much risk they can kind of take on and how much complexity they can take. It's like any other learner in a practice. If you're from a learning environment, the first 3 months are about a mutual assessment. There's induction and training, and I would be then assessing, you know, let's think about how you might approach this conversation with the patient. Do I feel okay with that? This is how I would do it. Let's debrief after you've spoken to the patient. I'm going to move us on because there's lots of, we're running out of time. So facilitating connections with the MDT, this makes a big difference where care coordinators have been introduced to the MDT early on and they go to all the MDT meetings early on. They have much more confidence in saying, oh, I could probably take that patient on. Why don't I take them onto my caseload and I'll link in with a link worker and I'll speak to the district nurses and follow up with the patient. they become a really valuable resource in the MDT if you introduce them and allow them to attend the meetings with the clinicians. The aspiration is, and I think the direction is, that they should really hold their own caseload. And this is where it's very different to kind of an admin bit of role. Ideally, care coordinators have their own caseload where they can follow up patients. And they need training on the clinical systems. Searches, templates, how do your templates work? How do you want them to work in your practice? There's no model for everybody. And coding. You know, there is a code seen by care coordinator that they should be using, because you need to know what the contact is. There's a SNOMED code, but actually you will have other codes that you want care coordinators to use, and that's part of the induction training. Really what this is about integrating them into your way of thinking alongside the GP. Ideally, a care coordinator should start with one clinical area alongside a GP who's an expert. For example, if you have identified a need in your area on your PCN around learning disabilities, if there's a population who has specific needs, that's where you could start with a care coordinator and at least one lead GP, train them up. They can apply the basics of personalised care planning and coordination with that cohort, develop confidence, develop skills, bring lots of questions. And then after 3 months, 6 months, add to it if that's what you need in your area. In some areas, there's a mixture. So people have one particular clinical area and they see a wide mix. They just get referrals of people with complex needs. That's totally okay if that's what you need. But what can sometimes happen is people who are new to the system can feel overwhelmed. So as long as there's a GP to go to ask questions from, that should be fine as well. But what I would say is start with one area, build the confidence, assess capability, add to it, and then widen their scope of practice. And again, care coordinators constantly feedback. The ones who have regular reviews with a manager and a GP and can say, well, this is not working, my appointment times are too short, I can see more people, can I take on more, I want to do more, are much more likely to stay in role, to develop, and do more meaningful work. So regular reviews built in for the first 3 to 6 months and then ongoingly adapted would be really useful. And then finally, we are in often a chaotic landscape. It's fair to say that there's a lot of vagueness in the DARES, and that's going to be reworded, perhaps. And that sometimes is quite a scary place to be. I would say as GPs in primary care, we are used to that. And there is an opportunity here for all of us, before the guidelines become very rigid and very didactic. I think this is the time to be creative, to really sit down and think about, get rid of all the noise, the banding, all the different things that are in the DARES, and just think what's at the heart of this role and how can we shape it creatively before the rigid rules come in. Almost certainly there'll be more guidance, which will help some people. But for me, the sense of uncertainty can also bring with it creativity. And that's where I think we were finding people are really flying across the country, with care homes. They're doing interesting stuff with care homes, with pharmacy links, doing stuff with dementia patients and cancer patients, because there's been a clinical team who's identified a need and they said, right, let's create it this way. Let's look at a pathway. I'm going to pause there. I'm happy to say a bit more about any aspect of that, but I just want to pause and just first of all just check whether that's making sense, but also if there are any questions that it would be helpful for me to answer that.
It's generating some really interesting discussion and some really useful questions.
Okay.
I'm going to save the one. There's a question around how do care coordinators address the fact that they're being used solely as an extension of the admin teams, because I feel like that's that could come later in the wider discussion around care coordinators, and it'd be good to hear some suggestions from the audience as to how you guys are making sure that care coordinators are being used in the way that Ali is describing. An interesting question we've had, which a couple of people have voted up, is it feels like you're talking very much about a model where a care coordinator is working alongside a GP. What about a model where there is a PCN care coordinator unit, a pooled team of care coordinators to be used PCN wide. What are your thoughts on that, Ali?
Yeah, so I think, again, this is where creativity can come to the fore. It depends what your local population needs are in your PCN. So you could easily have a model whereby care coordinators connect around a mixed caseload. That's one way of doing it. So there is a pathway in, and so they between them share a caseload. That's one way of doing it. Or you could have a mixture whereby you identify different areas of need, and different care coordinators in your PCN become the kind of the expert almost in that particular area. And what they can do is share, as long as they've got access to the clinical systems and they've got consistent coding and there's consistent follow-up and they have a clinical link, you could then cross-refer within a PCN to different care coordinators if they're working across several practices. That's totally fine. Again, there is no edict about how it should be done. I would go with what is the need in your PCN? Do you want a mixed picture where everyone shares the same caseload, or do you want to have experts and then people to take referrals and between them decide who would then follow them up, make contact? Ideally, that would need a PCN-wide referral routine, a central point of referral, and then the care coordinators between them can then figure out who would then do the follow-up, whose caseload that goes on. Does that answer, I mean, does that give you a sense of how it could be for whoever asked that question?
Feel free to unmute yourself if you feel like you need clarification.
Can you hear me?
Yeah.
Yes.
Perfect.
Yes. Yeah, that sounds kind of like what I was like trying to get at. Do you have you had any PCNs do this?
Yeah, I can come in if you want, and I can share an example if that would be helpful.
Yes,
yeah,
that would be great.
Yeah, so I mean, there is actually earlier today I had a conversation with a PCN CD who is doing exactly this. So they've got 8 practices and within the PCN, and 4 care coordinators who are taking a lead on different roles, and that's as Ali has mentioned, has come through by identifying what local needs are. So they've got a care coordinator leading on mental health, another one is leading on diabetes, another one leading on vaccination. So it's dividing up the work, and the care coordinators can refer to each other as well. So yes, that is something that's possible.
Okay.
And ideally, they would then work alongside the other personalised care roles. So the referrals may come in from the link worker, or they may come in from the coach, but they can also then refer to the others, so that they might identify, well, I'll do this bit of the personalised care planning, but also I'll refer to the coach, and I'll also refer to the link worker. So they hold, almost like a GP would do. I always see it as a mirror. As a GP, I often do that bit for patients. I know they're in secondary care, I know they're under the district nurses. I go to the MDT and say, what about psychiatrists? I follow them up. But actually a care coordinator can do the same thing. They can refer on, connect, and speak to others around that.
Okay.
Thanks. I've got one more question for you, Ali.
Sure.
What support and training does a care coordinator need? And I think that this connects really with another question that was coming through about who's best placed to supervise and look after the work of the care coordinator.
Yeah, so there are, as I said, hopefully the roadmap will clarify the national expectation. I don't want to speak out of turn, but I can tell you what I think is currently expected. In terms of training, as I said, the basic training will be first of all, the mandatory training that you will need, safeguarding training, all the mandatory practice training you will need for anyone. I think personalized care planning training, the e-learning module that's on there, on the platforms, the e-learning for health platform, is, I think, at the very basis of what they should all have. And then there are kind of different bits of training. So the personalized care institute, ideally in the DES and the guidance, that care coordinators should have training which is accredited through the Personalised Care Institute, the PCI. When you look at the website for the PCI, there's a lot on coaching skills and some on social prescribing, and there's very little on personalised on care coordination. But increasingly, some of those providers are providing modular programs, so that care coordinators can choose based on their experience which module. So that, for example, there may be shared decision making, which might be quite useful. There may be negotiating skills. There may be other elements of their role that they've never had training on. In some areas of London, so in Southwest London, the training hubs have got training for the patch in a modular way, so that any care coordinator can then is funded to choose which modules they want to do, and that's just about to start. I think other areas are looking the same approach. So Personalised Care Institute accredited training on the website, as well as the e-learning about personalised care. And then the secondary tier would then become specialist training. For example, if you're going to get somebody to work with dementia patients, they will need additional training around that. Dementia, consent, capacity assessment, they need to understand it enough to have conversations with the patient and their carers. So there is no one model fits all, but I think that's where the being clear about the role first and their prior experience, and then looking at what's out there to add on to it would be useful. So in terms of supervision, as I said before, I think the model whereby you have supervision, joint supervision is probably most useful. It's less overwhelming for you as managers and for the clinicians as well as times. So something whereby they need to have somebody to ask on a day-to-day basis if there's an urgent query. That's the first thing. For example, in my practice, you'd say, well, as long as the duty doctor knows that they may come to them for an urgent query, that's fine, because they've got somebody they can go and speak to if there's an urgent query that comes up, who can then, and the duty doctor could say, listen, this can wait. Speak to so-and-so next week or tomorrow, or we need to do something now. So there's on-the-job contact or advice. I think then there's something about regular supervision with a clinician. And that might be, once every couple of weeks, once a month, where you sit down, protected time, really, and I mean protected time, to look through the caseload, how things are developing, where the needs are, where the challenges are. And then there may be alternating that with a manager who checks in about the other aspects of their role, admin, time, capacity. And where that's happening, I think care coordinators really feel like they can expand this role and make it more useful for GPs. Does that answer the question from whoever asked it?
It does, that's really helpful. And I think if we've got time, we'll definitely come back to aspect of that. David's asking about an appraisal process and demonstrating competency. But I think this goes back to some of the things that Ali was talking about earlier about the roadmap that National are creating at the moment. And hopefully when that lands, we'll have a range of tools that we can use to assess where, when somebody comes new into post, as Ali was saying, obviously it's going to be really dependent on what they're coming with, who you've recruited and what skills and experience they've had prior to the role, as well as the specialisms that the specialities that you might be turning their work towards while they're in post. I'm very conscious of time. There's so much to discuss. Aidan, I think it'd be good to hear from Aidan a little bit about some of the projects you've been working on, and then Hina's going to speak to some of the ways that care coordinators have been used across London. I think some of these examples are going to maybe answer some of the questions around who should be, who a care coordinator might be working with, and what complexities, who should you be targeting in your work, and which patients, could you and should you be working more with.
Can I please just, sorry to interrupt, can I just ask one brief question that links in with what's been discussed? You mentioned management. Who do you mean by management? Who would be the management supervising care coordinators within practices? So, thank you.
What I meant is, for example, either if they're employed through the PCN manager, often it is a supervisor, and so they may have regular time blocked in for supervision to check how things are going, review the role. There may be somebody in your practice if you're employed through the practice. So a non-clinical, I guess, supervisor is what around half the care coordinators have a manager as their supervisor.
Lovely, thank you.
Thanks. Aidan, are you around?
Yes, I'm here. Can you hear me?
Yeah.
Yep, perfect. What I might quickly do is just give a brief rundown of sort of how my role sort of works in the surgery, just to help answer a few of the questions on the side and what's gone before. I'm Aidan, I'm a care coordinator. I am employed by the North Lambeth PCN, but I predominantly I work for one surgery, essentially. And the way in which I work is one of the partners oversees all our work and adds to a caseload. So I come in the morning, we have a morning MDT where all the clinicians get together, we discuss certain patients, what's going on, best pathways, all that sort of stuff. So I'm sat in there, I'm learning all this information, hearing about stuff. And we have a cohort of patients which we think are suitable, and it always goes through these meetings, or it tends to go through these meetings. So this would be people with severe mental illness, learning difficulties, severely frail, but sort of the overarching theme is the vulnerable, the people who aren't necessarily getting the equity of service that we'd like to provide, ideally. So, those that are lonely, without great support networks, that sort of cohort for Lambeth. Yeah, and so things are brought up in these discussions. The way we sort of operate is, I come from a background of working in GP surgeries, and I have a knowledge of the system, and I have quite a good knowledge of the community services available. And so the benefit that I can bring by adding to my caseload, we call the complex care caseload, is that I can almost do a bit more of the digging for the GP, find out what's going on. The GP, as we all know, 10 minutes, 5 minutes, 15 minutes, might not necessarily be able to start the investigations and all the different problems going on. Even today, for example, I went to visit a patient at home because there are a few discrepancies and a few phone calls coming up. We weren't quite sure what was going on. And I know this patient quite well, so I was just going through a bit of the background. What's going on here? Because we've heard this, what's going on there? And I gather all this information and I go back to that partner and I sit down and say, this is what I've gathered, this is what's coming. I find this bit a bit strange because of this, which I've picked up in the past. And then the GP will say, okay, and because I have a bit of knowledge of community services available, secondary care services, self-referrals, I can even suggest sometimes, I go, I know this clinic's running here, would this be appropriate? So it's a very good conversation we have. It's particularly as I've only done this role for about 8 months, it's not necessarily me just going ahead and taking control and doing everything, because that would involve clinical judgment, which I don't have. I don't have any piece of paper to tell me I can do that. So that's not right. So we work very closely. With the social prescribers, I tend to be a little bit of the gatekeeper for them. We have one that works for our surgery. Lambeth has a very mixed borough, lots of deprivation. We could send everyone to her and she'd be overloaded and useless, essentially. So I'm a bit of the gatekeeper. She communicates very well with what's available to me. So for the patients on my cohort, if it's just a one-stop shop, so for example, they need a new TV or something, I say, listen, the social prescribers told me about this, how about we put you there? Instead of putting them on the wait list for a social prescriber and then, clogging up social prescribers' times for other stuff. What sort of more do we want to? I also help with some other things. So I help facilitate certain multidisciplinary team meetings we have in North Lambeth. So we've got one called Staying Well, which is between with SLAM, social services and GP surgeries in North Lambeth. And I'll do a bit of the admin support, just make sure everything's run smoothly. But it's also a good place for me to sit because I'm listening out, learning about services available. I'm also, if any of the patients that I know on my lists come up in this place, I'm involved in the conversation. So if it comes back to GP a couple of weeks later because they've called up about something else, I can go to that clinician and go, this was discussed here, these are the concerns, etc., etc. So it's really, I think, about being a clear voice for the patient to the GP and vice versa. But I do have quite a lot of different bits and bobs with that. I think if we want to talk about perspective a little bit, if I've got the time, one of the big difficulties I think we had, well, the clinical director is also the partner of the surgery. And he was very clear with this sort of model, and we have really clear discussions. When we're doing this work, it works quite smoothly. I think the big problem is because a lot of care coordinators will have good knowledge of this stuff, they tend to be thrown into admin, and there doesn't tend to be much discussion around it. And a lot of people I've spoken to, they are employed on the basis of all the things Dr. Hassas has been talking about, and then they find themselves just on recalls, quaffs, and you don't have much support. I do find a lot of my time bickering back and forth, which drains you quite a lot. Saying, you know, I'm happy to help. If all our staff have gone sick, I'm the only one here, fine. I know what's going on, I'll do it. But it's that constant push back and forth, trying not to just be put into the admin, which I think is probably the biggest problem from my perspective so far.
I think that there would be a lot of social prescribing link workers as they were coming into the system and people didn't really understand their roles a couple of years ago saying the same. And the truth is that in some places it's going to be a much longer term battle than others. I'm interested to hear from the room though, if anybody, we are quite short on time, but if anybody's got any really good answers to this challenge around how we can support care coordinators into the work that was intended for them. Really interested to hear practical solutions to what is clearly a systemic challenge for making sure that your brilliant work is being made the most of. Thanks, Aidan. It was really useful, and I think, you know, it's you're speaking for a lot of people there. I think it's definitely the thing that people want to know the most about. I'm going to go to, I'm really sorry for those with their hands up, but we are very short of time. I'm going to go to Hina next, and to hear a bit more about some other examples, because I feel like that was one of the things that people really wanted when they signed up to the event, was to hear what's happening around London. Hina, are you there?
Yeah. Thanks, Leanna, and thanks, Aidan and Ali. So I'm just going to spend the next few minutes or so speaking about how care coordinators can be used to address health inequalities, their role in primary care, and just do a quick whistle-stop tour around London and present some of the really great work that we've been hearing that's being done across the city. So some of this may already be familiar to you, especially if you've attended previous sessions. So we know that over 80% of health outcomes are socially determined. That means that the conditions in which people live, work, play, and grow overwhelmingly influence their health outcomes, rather than kind of, you know, the biology and the genetics, which, you know, I have to put my hand up as a clinician is the way that we were taught traditionally, you know, when we went to medical school. A quick note also on health inequities, although this is a really kind of important concept to understand. We talk about health inequalities, but actually what we're speaking about is health inequities. So these are systematic, avoidable, and unfair differences in mental or physical health between groups of people. And, you know, we should at some point be thinking about changing terminology from health inequalities to health inequities to reflect actually the work that we're trying to do. And you may have also come across the term health disparities in kind of more formal government literature, for example, and disparities just kind of very briefly refers to differences between groups of people. And what we know is that health disparities are widening in the UK, and in particular in London, they're the highest. The RCGP, in the context of COVID-19 and the work that's been done by GPs, has identified a really vital community health function of general practice, and PCNs as being anchor institutions with exceptional potential to address and optimize both individual and population health outcomes, drive engagement between primary care and communities, and really promote cross-sector working. And some of you may have seen the guidance that's been published earlier this month on tackling neighbourhood health inequality as a supplementary guidance. So next slide, please. So in this guidance, there's a really strong focus on core 20+5, which some of you may be familiar with. So this looks at the 20% of the most deprived nationally deprived areas in the UK, identified by the IMD, so Index of Multiple Deprivation. And then the on top of that, ICSs will then choose particular population cohorts that reflect local needs and priorities. And then the +5 are the 5 key clinical areas of health inequalities that have been identified. And some of you may already be doing work in this area. So that includes maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension case finding. And a few other areas that have been identified in the supplementary guidance include what a health inequalities workforce should look like at the PCN level, what the PCN's responsibilities are, and proposed activities and some training available as well. So I'd really urge you to look at that guidance if you haven't already. Next slide, please. So how can care coordinators be used to address health inequalities? Well, the first step is understanding what the local data, your local needs are, because fundamentally addressing health inequalities involves understanding what the inequalities are in the local area in which you're working. So this may be by looking at demographics and segmenting your population, looking at differences in outcomes, experience and access. You may want to look at doing a needs or gap analysis, and there might be needs assessments that have been done in your area. Community outreach and engagement is a really important way of gathering important information about your local needs. And there's also a PCN Inclusion Health Toolkit, and we can put a link to that in the chat, which you can work through and see what some of your needs might be. And there are also lots of sources of data and insights which you might find helpful. So the PHE Fingertips database, integrated care systems dashboard, any audits that you've done, your QOF outcomes, outreach engagement that I've already mentioned, and MDTs. And it's really important to build local relations. So, between PCNs, trusts, CCGs, local public health teams, the third sector, voluntary sector, and as I've mentioned previously, really using PCNs as anchor institutions in the community. So where do care coordinators come into all of this? Well, the first thing is that it's really important to make sure that they are a key part of your PCN. It's really embedded and supporting the work that your PCN is doing, not just with practices, but also with those local community groups, and really building those multi-sectoral collaborations and relationships. So your care coordinators may be involved in proactive case finding to identify high-risk groups, assisting with overcoming those barriers to access that these vulnerable groups particularly face, and we know that we know about these access barriers, and Ali previously alluded to some of these. Their vital role in providing continuity and joined-up care, community development and building trusting relations, empowering self-supported management, self-advocacy is what Ali talked about early on in the session. And in some areas, they're being used to kind of look at what high quality, if there is high quality health literature that is available, that's relevant and understandable to particularly vulnerable groups who, for example, English might not be their first language, or who may have hearing or visual impairments, and they can really help with supporting some of the wider determinants of health, so training, employment, access to benefits, and access to personal health budgets where appropriate. And I know somebody mentioned that in the chat as well. Next slide, please. And these are some of the the data sources that you could use to help you identify what some of your inequalities are in your local area. Next slide, please. So I'm just going to do a really quick whistle-stop tour of some of the really great work that's happening across London. So looking at the 5 ICSs. So and actually some of this might answer the questions that have come up. And I know that there are people here who have been involved in some of the work in the PCNs that I'm going to be talking about. So, if that is you, then feel free to add to anything in the chat, or, if we have time later on to put up your hand and just talk about your experience and your role. So in Hammersmith and Fulham, we know that care coordinators are being used to join up the dots with care homes and care for multiple services. They're collaborating on weekly frailty MDTs and coordinating actions from this. And Harrow care coordinators are organising and facilitating long COVID clinics because there's a need that's been identified locally. And they're working alongside health and wellbeing coaches and GPs to really refine some of the referral pathways, to provide peer support, and some good outcomes of patients are being reported, from that piece of work. Also in Harrow, care coordinators are working alongside patients with severe mental illness and making sure that they have their health checks done as well. And they're also starting a frailty network in one of the surgeries there. Next slide, please. In NCR, some really good work that's happening in Barnet, and I know that we have somebody from Barnet here. So, targeting at-risk patients and high-risk cohorts, pre-diabetes, learning disability, weight management, supporting long-term care and long-term conditions care navigation, and really looking at working as one team with the other R's roles. So for example, if a care coordinator identifies any issues with anxiety and housing, that they're able to refer these patients onto the link worker. And where there are any issues that are identified with motivation and behavior change, then these are referred onto the health and wellbeing coaches. Also, care coordinators are doing home visits with GPs, working with complex care and housebound patients, and also raising any safeguarding issues to the GPs, working with patients with severe mental illness, with vaccines, high-risk drug monitoring, cancer safety support, blood pressure at home as well, and working with pharmacists on cough. In Camden, the care coordinators are working alongside link workers and providing workshops as well. And in Harringay, there's a specific homeless project where they are bridging the gap between primary care and the community and also supporting this very vulnerable population. Next slide, please. In North East London, so there's work that's being done, again, care coordinators working with link workers. So you can kind of see how care coordinators are working together with the other personalised care R's roles, and that's really central, central part of embedding them within PCNs. Also, they're reviewing care plans, reviewing A&E discharges, looking for trends and opportunities for early intervention, and there's a real push for this at the moment. They're also involved in digital waste management referrals, vaccines, and in a project improving safeguarding referrals across professionals. Next slide, please. In South West London, really interesting piece of work that's being done with home visits for patients who are not engaging with healthcare services. Also, again, case finding for blood pressure patients and referring them on to health and wellbeing coaches, and working very closely with health and wellbeing coaches, and that's been facilitated because they share an office space. In Sutton, a really interesting model that's developed there, which is looking at this neighbourhood model, so providing wraparound care around community assets, and the 3 R's roles are working, within this model to develop health champions, having regular meetings, again with the 3 personalised care R's roles. The care coordinators are currently involved more with vaccination, but there's, but there are conversations around them being involved in more kind of MDT work, cancer work, and merging with the personalised care team in the neighbourhood. And in Wallington, proactive outreach with underserved patients who are not engaging with services. Next slide, please. And finally, in South East London, we have heard that in some places they are taking most of the admin burden. Of course, we're trying to support PCNs to get them to think about the value of care coordinators beyond just administrative role. So they're acting as a main point of contact for patients with complex needs, or who may be who interact with the practice a lot. So frequent attendees or frequent callers, and they also attend monthly meetings to develop skill sets. In Lambeth, working with children and young persons in a project there, also as part of a Digital Champions program to tackle health digital exclusion. Aidan's already spoken about some of this work. In Lewisham, there's a really interesting model there where they've got a health inequalities lead at the PCN, really looking at community engagement and building a multi-sectoral forum. So they have representation from lots of different multi-agencies. The care coordinators are also involved in health checks, call and recall, and this has had a really high acceptance rate, which has been facilitated by using translators who actually speak the language of patients who may not be presenting or engaging with these health checks. And we know in particular ethnic minority groups have a low uptake of health checks, and this, this is an example of how that barrier can be overcome. And also starting a project on inclusion health groups using about 300 EMIS codes and using those to highlight risk, those who are at risk of health inequalities. Next slide, please. And outside London, so you may have heard this discussed previously. So in Barnsley, care coordinators are contacting patients who are not attending for their smear or fit tests as part of cancer, early cancer detection, cancer screening. And the care coordinators are also trained in coaching to encourage patients to attend appointments. They're also involved in building relationships with care homes, and are also trained in personalised care planning. And in Barnsley, they have, all of their care plans have been completed because of the training that the care coordinators have received. So lots to think about there, but some key messages. So the first one is that care coordinators are not glorified administrators. If you're working at the PCN level, but also as care coordinators, who would be interested in doing some of this proactive reach and supporting PCNs to have a more population health management approach, or to develop a health inequalities lens, thinking about how can you better understand your local population, what the needs and priorities are, how can you build relationships with local communities, and how can you co-produce initiatives and programs and really embed care coordinators in your PCNs at both the practice level within PCN and PCNs and MDTs, but also at the neighborhood and community level as well.
Really brilliant stuff. I think there's something around the co-production I've definitely heard of. I think in the Lewisham example, the care coordinator and their community development link worker, I think, have been working alongside their patient participation group to really understand what people with long-term conditions in their local area need from the services, because obviously it's a limited resource, and so turning it towards the things that are needed the most is really important. Thanks, Hina, that was fab. I know that we've got some people from the examples in the room. Is Rafif around? Rafif.
Yes, hi.
A really great example. You're a SPIN fellow, is that right?
Yeah, a SPIN fellow with Barnet Hub, and I've been sort of helping mentor, liaise, all of the above really, which isn't the best way to do things, but that's what we've done so far.
Do you want to say a bit more about kind of the project connecting the care coordinators and the link workers in PCN4?
Yeah, so I work quite closely with the social prescribing link working manager. So our link workers are managed through Age UK and the borough. So I think having close connections with herself as the manager, we've tried to bring the two groups together. One on a PCN level, so in certain PCNs where there's sort of an appetite for it, we bring them together every sort of 2-3 months just to touch base, especially as the link workers can sort of rotate across the surgeries, so that they have that networking, that access to the care coordinators and vice versa, so they can work together and sort of patients who share sort of similar complexities. In terms of distinction, we were quite worried about them, how do we distinct who needs a social prescriber, who needs a care coordinator, so between them they can sort of liaise and say, actually this person only needs a couple of things sorted, and maybe the care coordinator can deal with that. And then we've also started doing some quarterly meetings with the health and wellbeing coaches, albeit we've only got 3 in the borough so far, but there's appetite to bring them on, and sort of just cover a topic that might be of interest to all of them, and then check in with their kind of wellbeing and share any obstacles that they might be finding. And there's been a good reaction to that, and I think they all find it quite helpful to come together as new roles who have sort of similar agendas.
It's a really exciting project, and I know that I've already, as we'll say a bit more about the one-to-one support that Hina and I offer. We have a surgery every Wednesday for people to book in and have a chat with us talk through some of the challenges and opportunities around using these roles. I think I've put you in touch with a number of people already, and I think it's because I think what you're doing is seeing opportunities for these roles to be working together, and that's going to really help create some clarity within the PCN. We keep coming back to this question of how do we address the fact that care coordinators are being used solely as admin. I'm just thinking back to the story of the link workers. I think the only way is to create an alternate narrative and really prove the value of that. Have an idea, test it, record it, use your SNOMED codes, and for any referrals that you do receive, or proactive work that you are doing, make sure it's being recorded somewhere so that you can go and tell the PCN manager, the clinicians within your practice about the impact that you're having and the potential that you can have with through telling stories of what you have been able to do. Have you got any tips on, I mean, you mentioned something in the chat about contracting. Can you say a bit more about kind of how that might work and how you think that could support care coordinators in really reinforcing the value of work?
Yeah, I mean, It's more a question. I don't know whether that's something that's going to come down in the roadmap as well. So, I mean, the other thing I do is I sort of hold mentoring sessions or little huddles within the PCNs for the care coordinators to come and share their experiences. And this is something that comes up again and again. And I think one thing is, you know, empowering the care coordinators to go back and speak to their managers and their clinicians to tell them what their colleagues are doing in other places. So there is a lot of empowering work that you need to do. And I think it's a challenge that occurs in any work stream, but maybe care coordinators haven't had that sort of experience before. So sort of empowering them to be able to have those conversations. But I also have, you know, the question's been raised, actually, what is in your contract? And can you, in order to empower the care coordinator, sort of encourage them to speak to their managers about their contract and really clearly define what their roles are in order for them not to be used in other places where they don't find that, you know, they're being made of the best that they can. There was the other thing I was going to mention is about caseload. So I encourage the care coordinators to sort of have an Excel spreadsheet of the patients that they have and their caseloads at that particular point. One as a diary for themselves to sort of keep track of things that they need to do or come back to, and also for them to share with their managers or clinicians when questions are asked about, you know, what roles they are doing, or even, you know, as an auditing purpose, so we can share it across PCNs and share good work, as you say, so that we can sort of propagate the messaging across the areas. So I think the care coordinators who do that find that quite helpful, and from there, their job has sort of progressed and they've taken on even more complex patients, and that way their experiences grow as well.
Absolutely. And I think they're very lucky to have an ally in you. And that's why I would say to any care coordinator on the call that go and find your allies. And there will be people on this call who perhaps need to go and find their, you know, can go and find their care coordinators and to sit down and have a conversation about what are the needs of the local population and how can the care coordinator role be supporting that. I thank you, Rafif. I think that's been really useful. Obviously, this is a subject in development, and as Ali pointed out earlier, where there is a lot of uncertainty, that actually creates a lot of opportunity for us to create and to do something really exciting, and perhaps to forge on with our own plans around kind of what is needed. I'd be interested to hear from the room about any other ways that care coordinators have been used. I know that we've got Alison Hope in the room, who had a good example about how the care coordinators have been used to support.
Hello.
Just conscious that, I mean, actually sometimes some of the ways to, I'm thinking about the link workers, some of the ways to really convince that of the value of these roles is by thinking about what are some of the key challenges the surgery or the practices and the PCNs are facing, and turning the superpowers of the care coordinator towards solving some of those problems. But yeah, it'd be great to hear from you, Alison, around sort of your example of that.
Hi, yes. Can you hear me? Hello?
We can hear you, yeah.
Okay. Yeah, so what we've been doing is we've been using the care coordinators to process our online consultations and direct them according to our clinical protocols to other members of the PCN team. So, for example, we have a paramedic, and so certain e-consults will always go to the paramedic, and then most go to the practice. But
I think your internet is maybe not so great.
We've got about at least 20% on. I've been holding my phone up to the window for most of the meeting.
I think, do you know what we'll write down your example, Alison, and we will share it in the slides after the session. I'm just thinking we've only got 5 minutes left. it feels like we've covered most of the questions. There are a few there that I think are quite practical things that we can certainly pop into an FAQ and add to the slides. Jenny, could you go to the slides on the work of some of the PCN advisor work? I just want to let everybody know about some of the ways in which you can access additional support. So we've talked a lot today about some examples around London. Actually, it'd be really lovely if people could connect outside of these meetings. We've created a WhatsApp group that you can join. It's not very active at the moment, but I think as more people join, and you know, it's a great place. We have one for social prescribing managers, and it's a really great place for people to ask questions of each other. And once I think useful questions are coming up and useful answers are returned, things like that start to get busier. So I think it is a good way for people to connect outside of the meeting. So please feel free to join the WhatsApp group. Hina and I offer a few sessions a week, surgery time, just to come and have a chat about maybe some of your challenges or opportunities to embed these roles, to have a bit more of a focused session. So please feel free to book into one of those. We have a monthly email that goes out, and we'll be covering other events, resources we come across, interesting guidance that's useful, and any interesting publications relevant to the work, and hopefully, you know, things that you send us that you have found really useful in your work, so that we can share with others. What we're really into here is making sure that people aren't reinventing the wheel. So please feel free to keep in contact and share some of the useful resources you're coming across, so we can share with the wider network. That will be hopefully feeding into a PCN toolkit that we're working to create now. If you go to the next slide, or sorry, the events slide. So the next session, we've got a back catalogue of a few different events that we've run of this nature. You can find the recordings, some of the recordings and slides on our website. The next session that we have upcoming is a spotlight on health and wellbeing coaches and how best to use them. And hopefully we'll be having a showcase in April of how the personalised care roles are tackling health inequalities. So a bit more of a in-depth look at some of the really exciting teams doing some very innovative things, and really banging the drum for why these roles are so useful in, you know, for the ways that primary care networks and surgeries are working, but also how important it is for the patients that we're supporting. Just a huge thank you to all of the speakers today. It's been really great to hear from everybody, and I'm sorry for those that had questions that we didn't get to. You can keep in touch with us via the email address, which is not on the screen at the moment, but we will, yes, there we go. So please, any questions, thoughts, ideas, stuff we're not doing that you think we should be doing, please do get in touch. And as I say, these slides, the recording, answer to the questions that have been asked will be circulated after this event. I'm going to stick around for 10 minutes if anybody wants to stop and chat. Otherwise, really lovely to see you all, and hope to see you at the next session. Thank you.